Welcome everyone to the GRNEN Ambassador conversation. The topic for our discussion today is hypertension. My name is Audrey Snyder, and I am faculty at the University of North Carolina, Greensboro, and I'm one of the co-founders of the Global Rural Nurse Exchange Network. And first, and everyone hopefully can just unmute, and unless there's background noise, and all of us kind of talk to have this as a conversation. It's not really a presentation by me today. But to start with, I'd just like to ask, how prevalent is hypertension in your community, in your country? Is this something that you see as a highly prevalent condition that impacts the population that you work with as a nurse?
I'll respond. Certainly here in the U.S., it's a huge issue, and especially both undiagnosed hypertension, but also unmanaged or hypertension that leads to stroke, cardiovascular disease, and others. So yeah, certainly, and we have in some ways in southern Utah, so looking directly at the population, we have a younger state, so it doesn't impact younger people as much, but we also have a growing older population. A lot of people retiring to the Southwest, so it's a huge problem there as well.
Thank you, Mark. How about our other colleagues on the discussion today?
Hello.
Hi.
Yes, this is Daiwo from Ghana, Sanford.
Welcome.
Thank you. So hypertension in Ghana, it's of high prevalence, and it's very common among people aged 20 to 50 years, definitely higher among the elderly. But we have a very high risk pre-hypertensives in Ghana as well.
Thank you, Thao.
Hi.
Hi, Betty.
Hi. So I'm going to talk briefly about hypertension in Malawi. So we have a prevalence of about 33% for adult population. That's from age 25 to 64 years. And take note that those are the ones that we get to diagnose. But most people, they come to the clinic or the hospital, brought in date, and then the underlying cause, you'd see that they had stroke. So probably we have a lot of people that are not diagnosed. How it's hard to know that you have hypertension until you get those signs, and then you come to the clinic. So apart from having the 33%, we have a lot that are in our area that are not diagnosed. Thank you.
Gladys or David, would you like to share?
Okay, hello everyone.
Hi.
Yeah, by the way, in Tanzania, also, we are just having a high prevalence rate of hypertension, but most of the patients are just coming late to the hospital as they have already got stroke, and most of them are elder, starting from the age of 40s to 60 years. So most of them, they are just coming with the late. So you can't manage most of the patients with stroke, because most of them, they are just coming with hemorrhagic stroke, of which you can't do anything in our facilities. Thank you.
So it sounds like long-term sequelae for those who do have hypertension that result in a hemorrhagic stroke is significant.
Yeah. Yeah.
David?
Yes, how are you, Audrey?
I'm well, David. Glad to see you on today.
Yeah, thank you. But the ideal situation is that normally, the ideal when patients come to our office, they're supposed to be taken vital signs, and blood pressure is one of them. Most of the time, it is ignored, and clinicians and physicians only take blood pressure when they suspect that somebody might have hypertension. If for that reason, there are so many clients who have hypertension and do not know. But I could have given the prevalence, but I know it could be more. Just like any other African countries, Most patients are diagnosed when they have had a complications, probably renal failure, stroke, and other things. So what we were planning to do, which we thought that we could partner with this GRNEN, is that we do some routine check, especially for the 60+ years, on either yearly or after 6 months. From there, we can pick a lot and we can have a case to bring up. However, next time, after this meeting, I'll go and check the prevalence in Kenya, which is recorded, and then I share. Thank you, Audrey.
Thank you, David, for sharing that. What do you all feel contributes to the hypertension in the region that you're in?
So mostly, one, the lifestyle. People have ignored that eating habits have changed to the, and also exercise, people are lacking exercise, and people are not eating healthily. And another thing that it is ignored by the government of Kenya. Non-communicable diseases has not been given more attention. So those are the contributing factors. So you will find that for HIV drugs, they don't buy, but for the antihypertensives and the checkups, you have to buy, and the costs are very expensive. Thank you.
So cost is a factor.
And I would concur with David. Here in the U.S., it's mainly lifestyle related in terms of diet, exercise, and then again, lack of compliance. I think not, and maybe especially with cost as well. Although most of the hypertensives that I'm aware of are fairly low cost, if there's still a cost if you don't have health insurance.
And I know that many times hypertension has been termed the quote silent killer. And that's because many times people do not feel bad until they have complications of the hypertension. So if their blood pressure is up a little bit and they can't feel that their blood pressure is up a little bit, they may not be willing to take a pill for it on a daily basis or twice a day, as some patients may need to. So many times there's this disbelief. I think diabetes and hypertension both kind of run hand in hand for that area. Unless people feel bad, then they don't feel like there's a need to take a pill or to have their high blood pressure treated. Considering the cost associated with medications for hypertension, how do nurses in your clinics in your area work with patients? What sort of focus do they have from a patient education or care perspective for those clients that have hypertension but maybe can't afford the medications?
So what the nurses do, the nurses try to give health education on lifestyle, but now the challenge is that there is no mechanism to follow up patients at home. Remember, antihypertensives are not admitted, and after some times, they go home. One of the things that nurses also do is to book them for medical clinics, which they're supposed to come every month. But that one does not happen well because of cost related. Because when they get home, they don't have money, they don't comply. So I want to say that management of non-communicable diseases, hypertension, diabetes, cancer, is poorly managed in our country. And one thing that I learned with another patient who was diabetic is that even the updates are not there. The doctors and the physicians and the nurses are still using the knowledge that they used when they were in training. And remember, some even left over 30 years ago. So this is a real challenge. Just to contrast to other diseases like HIV, where partners are really coming up, there are a lot of updates, but where the country are left to manage on their own, Audrey, there's a challenge. Yes, as you said, it's silent killer. We only admit patients when they have complications and the prognosis is poor.
Debbie, could you share a little from your area about the nurse's role as associated with hypertension management or treatment or education?
All right. Basically, in Malawi, it's not quite different with what's happening in Kenya. We have clinics, outreach clinics. We conduct some checkups in the villages, like with, for example, I'm in the academics, so I teach community health nursing. So we also conduct checkups, like we go to the village, we set up clinics and then do checkups, and also we educate those with hypertension. We follow up with their diet, but then there are a lot of challenges, you know, because most of our population live below $2 per day, and then for them to find the appropriate diet is very difficult. So even when you talk of exercises, with our culture, it's kind of rare in our rural communities to see an adult exercising. So we really have a long way to go, but basically we do healthy talks. A lot of them are not really compliant. So we also depend much on the pharmaceutical side, where they go for maybe monthly clinic visitations. But then I already know, I wouldn't say we are quite effective because of low healthcare workers population, and also with high percentage of the clients that we have. But hopefully we'll get there. Sure.
I know I did some work in a very rural area in Virginia, in Appalachia. And one of the challenges working with my students that we had was, again, you know, when people live in cities, they may have more ability to walk because there's sidewalks, but we're in the US, but when you're in a rural area, walking on rural mountainous roads, you can be killed because there's really not an edge, you know, to walk on. So our students came up with a whole lesson plan that focused on, because dance is such a big part of that culture, and maybe that's the case in some of your cultures, to focus on dancing and how dancing can increase cardiovascular health and increase mobility. 15 minutes of dancing can equate to 10,000 steps. So that was one thing that one of my groups of students really worked on, with an area where that, because many times people are working hard in the rural area, but may not be able to do what we would term in the healthcare area as exercise. That may be something to consider, is how could dance be integrated into a lifestyle that focuses on increasing exercise in a way. Gladys or Thywald, do you have anything to add from your areas?
Okay, thank you, Audrey. I think lack of follow-up is a huge problem in our country, because once you have been attending a client in the clinic, most of them, they lost. And once they have been diagnosed with hypertension, they prefer to use herbs rather than to use pharmaceuticals. So lack of follow-up for those clients, it's a huge problem in our country.
Are there specific herb names that they tend to use to self-treat for high blood pressure?
Yeah, there are some. Okay, then I'll search for it and then I'll send it to you so that you could know the names.
I was just curious. I know that with the work that I do in some of the Caribbean countries, they tend to call anything that they collect and dry and may turn into a tea, they just call them bush teas. And lots of times it's hard for me to get down to, like, what exactly is the plant that, you know, you're pulling these leaves from, that you're seeping in water and turning into tea to self-treat. So I'm always curious what in our country we would term to be maybe folk remedies in the US that people do use. One of the studies that I did a long time ago that was also in Appalachia, the residents there said, yes, I would prefer to go to a doctor, but if a doctor is not accessible, then I'm going to do things that have been handed down through the generations and taught in my family to use to treat these conditions. Because if I can't get access to a physician or I can't afford the medicines, the herbs may be growing in my backyard or in the mountain, and I can get those and use those. So I'm always fascinated by the ingenuity, in a way, of people to try and get or self-treat for things that they've been told they have. Are there common medications in your regions that are used? I know many times the names may not translate here into the US, but are there common medications that you see used for hypertension?
Hi, so in Malawi, we use the stepwise antihypertensive treatment approach, which if we're newly diagnosed, we start with thiazides, like hydrochlorothiazide or bendrofluazide. So if it doesn't work, we go to step 2, where we add calcium channel blockers to the thiazides. And then we go up to adding angiotensin converting enzyme. So we go up to step 4 and then step 5, where then that's when we have really problems. And on step 5, we add beta blockers to step 3. So this is like the new recommended pharmaceutical management of hypertension here in Malawi. So all the facilities, they use that because it's on in the we have the chart that we use by the Ministry of Health that is supposed to cut across the whole country. Sure.
Debbie, it would be great if you had like a picture of one of those charts to share within the GRNEN discussion group, because that would be interesting to see. And we could do the same thing. We could provide a US, protocol. And if anyone else has a protocol that your country is using that guides treatment, that would be good to see.
Okay, I'll do that. Thank you.
Yeah.
I guess I would also ask, are there things that you think from a nurse providing education with patients that is effective in changing health outcomes related to hypertension?
Well, if I can just real briefly talk about, again, as even with antihypertensive medicines, I'm not a clinician, but lifestyle change is always, again, one of the recommendations to try and include that, whether that be increasing physical activity, trying to reduce sodium in your diets, more sleep. And so I think from a nursing perspective, one of the areas that I think is really under valued in nursing is working with patients on lifestyle modification. And so a number of, whether it be working with a DASH diet, but it's limited by the ability of nurses to have the time, and time gets to be reimbursement with money. And so we oftentimes will reimburse clinicians for, which again is important for prescribing a medication, but we won't necessarily reimburse for behavioral health specialists to help and coaches to help people change their lifestyle as well.
So true. Well said, Mark.
Yes, Audrey.
Yes.
Yeah,
David?
we have a guideline on management of hypertension, but just as the challenge still we have is the implementation, because yes, I say that we are really, as a country, we are really doing poorly. So the management will depend. So when the guidelines are not rolled out, especially the rural areas, now individual physicians and nurses use their judgmental. So they just combination of diuretics, beta blockers, their sites, but I'll send you the guideline. But the role of nurses is purely health education and drug compliance. is when now they also to note only that is when the nurse practitioners is coming well in Kenya. For the so many years, nurses have been, if they are working in big hospitals, they have been just dispensing and following the physician's orders. But now what they do is health education on compliance, healthy living, and to ensure that the clients attend clinics regularly. One thing that I learned in my village, the nearest health facility, I went there last week, and there was the battery for the blood pressure machine was not working, and that one has been there for 1 month. So this one tells you how our government is doing very little in managing hypertension, and because nurses are also not cannot buy those things, they just do what they can. Okay, probably in a while you will also share with us what happens in your country.
Yeah. And I know the patient education part is so important. In some of the Caribbean countries, from a preservation of food perspective, for example, fish plays such an important role, but because of historically not having refrigeration, even though there is refrigeration now, they would salt their food. So they would make salt fish. So they would preserve the fish by drying it with salt. And so a lot of education has to focus on when you soak that fish, frequently changing the water out to decrease as much of the salt as possible to, again, try to decrease the salt in the diet. And even in the rural area that I grew up in, canning of fruits and vegetables, it was common practice putting salt in, canning beans, for example, or canning corn. And so now we've got to focus on, don't use grandma's recipe for your canning. Let's talk about how you can preserve those same foods with canning without using the quantity of salt. In the US, we have a salt substitute. Do you all have salt substitutes in your countries that patients might use if they really need or like that taste of salt? Here, some of them are called no salt. Frequently, they have potassium in them. So that becomes a challenge for anyone who has renal disease. And when we think about the complications of hypertension, renal disease is we've talked already about strokes, which can be a significant factor in heart disease, but kidney disease is also a potential outcome of sustained hypertension that's not treated. And so that becomes a challenge. So I, want to make sure that patients have some lab work done before they start transitioning from using salt to using a salt substitute that might be high in potassium, which could, if their kidneys aren't working well, could lead to high potassium levels in the blood and affect the cardiac or heart conduction system. So I don't know if you all have anything similar that you're working with the clients that you see.
I don't know any salt substitute, but what we do that we only tell the patients to use like garlic. Yes, the garlic and other things that can make food better, but we tell them not to take salt, but use other like garlic and ginger, just to improve the quality of food. But I can still find out if there's any alternative. Yeah.
And those are great suggestions. I know that I worked with some low-income women on a heart healthy cooking class with the American Heart Association. And we did kind of this triad of health screenings, teaching them about how to cook from a more healthy perspective, and did cooking classes, with them. And then with that, had a nutritionist who really focused on the nutritional value of foods and how you can adjust to make what you're cooking more healthy. And out of all that we did, the area that in the surveys that the women, and this was a completely women's group, that they said was the most helpful was actually the nutrition piece, because they see a lot in the media on how to cook, and they see a lot about what are the parameters your blood pressure should be. And they, get height and weight done and an indication of body mass index when they see a clinic, but they weren't getting any nutrition classes or any nutrition information. And so we did a big focus, and if I was to redo that, that's where I would put most of the energy in. We just finished this study this spring, but to really think about what we're educating patients about from a nutrition perspective and giving them the tools that they need to try and make some of those lifestyle modifications and change how they prep their food and what they're cooking. I don't know if any of you have had any things that you found have been successful in your regions in working with clients to try and do more of the lifestyle modifications besides what you've already said today.
Hi. In Malawi, also for those that can manage, they are encouraged to use Himalayan salt, as it is believed to be lower in sodium than the table salt that we use. And basically to avoid cholesterol issues, they are educated about maybe boiling or roasting their meals, and to avoid as much as they can red meat, to at least to stick to lean meat or maybe a vegetarian diet if they can manage. But as you know, many are not compliant, but also others, vegetarian diet is not favorite, so it's kind of tricky, but those that can, they try. But I might say that success rate is not as we plan to achieve, but yeah, we'll still continue educating, exercises, and the diet, because it's very, very vital with hypertension management. Yeah, thank you.
Thank you for sharing, Fabi. Well, our time is winding to a close. I appreciate all of you. It looks like Will has dropped off, but Fabi, Gladys, Mark, David, for sharing about the experiences where you're at. It sounds like we have a lot of similarities in as far as focus and the potential for there not being easy access and treatment without there being significant cost, which is prohibitive for many of the clients, that everyone's focusing on patient education to look at lifestyle modifications and trying to address, some of the things like lack of exercise, eating less red meats, focusing on some other aspects, maybe the Himalayan salt or no salt. I see Mark has his hand raised, so let me give Mark an opportunity to speak.
Yeah, again, thank you, Audrey. This was a great presentation. I put a link in the chat box to the Million Hearts campaign. I'm sure you're familiar with that, Audrey, but it's a great resource here in the U.S. Around preventing cardiovascular disease, and including the root causes such as hypertension. And so that might be a resource. It's free out of CDC. That might be some resources that people in some of the other countries might be able to take a look at and get some ideas. But I really like it because it's perfect for nursing students. We can involve nursing students at their level of training to help people and provide lots of information. So, but thank you again, and wonderful to meet everybody.
And Gladys, your hand's up next.
Yeah, thank you, Ari. But you know what? Once we are providing health education on diet, most of the compliances are from the age of 60s and above. But at the age of 30s and 40s, they are not the best compliances on the diet. Most of them, they can't.
Thank you for sharing that. Well, I hope all of you have a wonderful remainder of your day or afternoon. And we will get this posted to the GRNEN group discussion for the ambassadors. Fabi, I see your hand up as well. Give you a chance to speak.
Yes, just following up to what Gladys was sharing recently, are there other mechanisms that you do in order to improve the client's compliance to the management of either hypertension or diabetes that has worked in your communities? Maybe we can learn a thing or two. Sure.
That sounds great. And once we get things posted, everyone share things that are resources from your area. And I think this is a great way to kind of have some cross-cultural, maybe something that's working in one country may be helpful in another.
Thank you, Audrey. I really appreciate you taking the time to do this today. So thank you so much, everybody. Have a good rest of your day.
Thank you.
Thank you.